Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, a companion podcast to the journal. Continuum Audio features conversations with the guest editors and authors of Continuum, who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article by visiting the link in the show notes. Subscribers also have access to exclusive audio content not featured on the podcast. As an ad-free journal entirely supported by subscriptions, if you're not already a subscriber, we encourage you to become one. For more information on subscribing, please visit the link in the show notes. AAN members, stay tuned after the episode to hear how you can get CME for listening.
This is Dr. Erin Berkowitz, and today I'm interviewing Dr. Sarah Wahlster about her article on examination and workup of the neurocritical care patient, which is part of the June 2024 Continuum issue on neurocritical care. Welcome to the podcast, Dr. Wahlster. Can you please introduce yourself to the audience?
Thank you very much, Erin. I'm Sarah Wahlster. I'm a neurologist and neurointensivist at Harborview Medical Center at the University of Washington.
Well, Sarah and I know each other for many, many years. Sarah was my senior resident at Mass General and Brigham and Women's Hospital. Actually, Sarah was at my interview dinner for that program, and I remember meeting her and thinking, if such brilliant, kind, talented people are in this program, I should try to see if I can find my way here so I can learn from them. So I learned a lot from Sarah as a resident. I learned a lot from this article, and excited for all of us to learn from Sarah today, talking about this important topic. So to start off, let's take a common scenario that we see often. We're called to the emergency room because a patient is found down, unresponsive, and neurology is called to see the patient. So what's running through your mind? And then walk us through your approach as you're getting to the bedside and as you're at the bedside.
Yeah, absolutely. And this was a fun topic to write about because I think this initial kind of mystery of a patient and the initial approach is something that is one of the puzzles in neurology. And I think especially if you're thinking about an emergency, the tricky part is that your evaluation and your management go hand in hand. And the thinking I've adapted as a neurointensivist is really thinking about column A, what is likely, and column B, what are must not miss things. It's actually something I learned from Steve Greenberg, who was a mutual mentor of us, but he kind of always talked me through that. And so there's always things at the back of your head that you just want to rule out. And I do think you evaluate the patient having in mind what are time-sensitive critical interventions that this patient might need. And so I think that is usually my approach. Those things are usually anything with elevated intracranial pressure is the patient at risk of herniating imminently and would need a neurosurgical intervention, such as an EVD or a decompression. Is there a neurovascular emergency, such as acute ischemic stroke, a large vessel occlusion, a subarachnoid hemorrhage that needs emergent intervention? And then other things you think about are seizures, convulsive, non-convulsive status, CNS infection, spinal cord compression. But I think just thinking about these pathologies somewhere, and then really approaching the patient by just very quickly trying to gather as much possible information through a combination of exam and history.
Great. So you're thinking about all these not to miss diagnoses that would be life-threatening for the patient, and you're getting to the bedside. So how do you approach the exam? Often this is a different scenario than usual, where the patient's not going to be able to give us a history or maybe necessarily even participate in the exam. And yet, as you said, the stakes are high to determine if there are neurologic conditions playing into this patient's status. So how do you approach the patient at the bedside?
So I think first step in an ICU setting, especially if the patient has a breathing tube, is you think about any confounders, especially sedation or metabolic confounders you want to remove as soon as possible, if able. I think as you do the exam, you try to kind of incorporate snippets of the history and really trying to see, localize the problem and also kind of see, what is the time course of the deterioration? What is the time course of the presentation? And that is something I actually learned from you. I know you always had this framework of what is it, where is it? But I think in terms of just a clinical exam, I would look at localizing signs. I think in the absence of being able to do the full head-to-toe neuro exam, interact with the patient, you really try to look at the brainstem findings. I always kind of look at the eyes right away and look at, I think, just things like, the gaze, how is it aligned? Is there deviation? Is there a skew? What do the pupils look like? Pupillary reactivity. I think that's usually often the first step, that I just look at the patient's eyes. I think other objective findings such as brainstem reflexes and motor responses are also helpful. And then you just look whether there's any kind of focality in terms of, is there any difference in size? But I think those are kind of the imminent things I look at quickly.
Fantastic. Yeah. And most of the time, right, this evaluation is happening kind of en route to the CT scanner, or maybe a CT has already happened. So let's say you're seeing a patient who's found down, the CT has either happened or you ask for it to happen somewhat quickly after you've done your exam. And let's say it's not particularly revealing early on. What are the sorts of things on your exam that would then push you to think about an MRI, a lumbar puncture, an EEG? You and I both spend time in large community hospitals, right, where found down is one of the most common chief concerns. And in many cases, there isn't something to see on the CT or something obvious in the initial labs. And the question always comes up, who gets an MRI, who gets an LP, who gets an EEG? And I'm not sure I have a great framework for this. Obviously, you see focality on your exam, you know you need to look further. But any factors in the history or exam that, even with a normal CT, raise your suspicion that you need to go further?
It's always a challenge, especially at a community hospital, because some of these patients come in at 1 a.m. where the EEG is not imminently available. But I think, let's say the CT scan is absolutely normal and doesn't give me cause, but there's an acute concerning deterioration, I think both EEG and LP would cross my mind. MRI, I kind of see a little bit as a second day test. I think there's very rare situation where an acute MRI would inform my imminent management. It's very informative, right? Because you can see, very small vessel strokes. Like we had this patient that actually had like this really bad vasculitis and we're able to see the small strokes everywhere in the MRI the day later. Or, sometimes helps you visualize acute brainstem pathology. But I think even that, if you rule out a large vessel occlusion on your CTA, there's brainstem pathology that is not imminently visible on the CT. It's nothing you need to go after. So I do think the CT is a critical part of that initial eval. And whereas I always admired the neurological subspecialties such as movements, where you're just like, your exam is everything. I think to determine these acute time-sensitive interventions, the CT is key. And, also seeing a normal CT makes me a little less worried. But, you always look at these 4H, they're big hypodensity, hyperdensities, any shift, is a hydrocephalus, a herniation. I think if I don't have an explanation, my mind would imminently jump to a seizure or CNS infection, or sometimes both. And I think then I would really kind of, to guide those decisions, and whether I want to call in the EEG tech at 2 a.m., I would, again, look at the history in the exam, see if there's any gaze deviation, tongue biting, incontinence, anything leading up towards seizure. I think, though, even if I didn't have any of those would strengthen my suspicion. If I really absolutely don't have an explanation and the patient off sedation is just absolutely altered, I would still advocate for an EEG and maybe in the meantime do a small treatment trial. And I think with CNS infection, obviously there are patients that are higher risk for it. I would try to go back and get history about prodromes and, look at things like the white count, fevers, and all of that. But again, I think if there's such a profound alteration in neurologic exam, there's nothing in the CT and there's no other explanation, I would tend to do these things up front because, again, you don't want to miss them.
Yeah, perfect. So many pearls in there, but one I just want to highlight because I'm not sure I've heard the mnemonic. Can you tell us the 4 H's again of sort of neurologic emergencies on CT?
Yeah. So it's funny, the 4 H's, I'm actually not sure where that's coming from. And I learned it from one of my fellows, one of our Neurocritical Care fellows. He's a fantastic teacher and he would teach our EM and anesthesia residents about it and his approach to CT. But yeah, the 4H, he was always kind of like, look at the CT. Do you see any acute hypodensities, any hyperdensities? And hypodensities would be an evolving infarct or edema. Hyperdensities would be most likely hemorrhage, sometimes calcification or other things. And then do you see hydrocephalus? Because that needs an intervention. And look at the midline structures and, the ventricles. And then do you see any signs of herniation? And he would go through the different types of herniation. But I thought that's a very good framework for looking at the non-con and just identifying critical pathology that needs some intervention.
Yeah, so hypodensity, hyperdensity, herniation, hydrocephalus. That's a good one. The 4 H's. Fantastic. Okay, so a point that comes up a few times in your article, which I thought was very helpful to walk through, and I'd love to pick your brain about a little bit, is which patients need to be intubated for a neurologic indication. So often we do consultations in medical, surgical ICUs. Patients are intubated for medical, respiratory reasons, but sometimes patients are intubated for neurologic reasons. So can you walk us through your thinking on how to decide who needs to be intubated for the concern of depressed level of consciousness?
It's an excellent question. And I would bet there's a lot of variation in practice and difference in opinion. And it was actually the 2020 ESICM guidelines kind of commented on it. And those are great guidelines in terms of just intubation, mechanical ventilation of patients, and just acknowledging how there is a lack of really strong evidence. I would say the typical mantra, GCS8 intubate, has been proposed in the trauma literature. And at some point I actually dug into this to look behind the evidence. And there's actually not as much evidence as it's been put forth in guidelines. And that kind of surprised me. That was just recently. I was like, actually, let me look this up. And I would say I didn't find a ton of strong evidence for it. And I would say as neurologists, I'm amazed because GCS, I think, is a in some ways a good tool to track things because it's so widely used across the board. But I would say as neurologists, we all know that it sometimes doesn't account for some subtle nuances. Like, if a patient is aphasic, if a patient has an eyelid opening apraxia, it can always be a little confounded. And I'm amazed that GCS is still so widely used, to be frank. But I would say there is some literature or some school of thought that maybe just blindly going by that mantra could be harmful or could not be ideal. I would say, I look at the two kind of functional things, oxygenation and ventilation. I think in a neuro patient, you always think about airway protection or the decreased level of consciousness being a major issue. What is truly airway protection? It's probably a mix of things. And then there's the issue of kind of respiratory centers and respiratory drive. But I think those are two issues you think about. But ultimately, if it leads to insufficient oxygenation, hypoxia early on is bad, and that's been shown in several neurologic acute brain injuries. I think you also want to think about ventilation, especially if the mental status is poor to the point that the PCO2 elevates. That could also augment an ICP or exacerbate an ICP crisis. Or sometimes I think there's just dysregulation of ventilation, and there's hyperventilation to the point that the PCO2 is so low that I worry about cerebral vasoconstriction. So I worry about these markers. I think the oxygenation, I usually just kind of initially track on the SATs. Sometimes the patient is profoundly altered. I do look at an arterial blood gas. And then there are things like breathing sounds, right? Stridor, stuttor, the work of breathing. And I think something that also makes me have a lower threshold to intubate is if I'm worried and I want to scan and I'm worried that the patient can't tolerate it. And I want an imminent scan to just see why the patient is altered or seizing or presenting a certain way.
All great pearls for how to think through this. Yeah, it's hard to think of hard and fast rules, right? And you can get to 8 on the GCS in many different ways, as you said, some of which may not involve the respiratory mechanics at all. So yeah, that's a helpful way of thinking about it that involves both the mental state, kind of the tracheal apparatus and how it's being managed by the neurologic system, and also the oxygen and carbon dioxide sort of respiratory parameters. So linking all those together, that's very helpful. And related question, so that's sort of for the patient with central nervous system pathology who were thinking about whether they need to be intubated for a primary neurologic indication. What about from the acute neuromuscular perspective? So patients with Guillain-Barré syndrome or myasthenic crisis, how do you think about when to intubate those patients?
Yeah, absolutely. I think that's a really important one. I think especially in a patient that is rapidly progressing, you always kind of think about that and you want them in a supervised setting, either in the ER or in the ICU. There's some scores. I think there's the EGRIS score and there's some kind of models that predict it. I would say the factors within that model, and based on my experience, are often kind of the pace of progression of reflexes motor syndrome. I often see things like kind of changes in voice. In myasthenia, you look at things like head extension, flexion, those are kind of factors. I would say there's this 20, 30, 40 rule about various measures of like NIF and vital capacities, which is great. I would say in practice, I sometimes see that sometimes the participation and how the NIF is obtained is a little bit funky. And so I wouldn't always blindly go by these numbers, but sometimes it's helpful to track them. If you get a reliable kind of 60 and suddenly it drops to 20, that makes me very concerned. But I would say in general, it's really a little bit the work of breathing, looking at how the patient looks like. There's also at some point ABG abnormalities, but we always say, once those happen, you're kind of later in the game. So you should really, I think anyone that is in respiratory distress, you should think about it and have a low threshold to do it. And at a minimum, monitor very closely.
Yeah, we have those numbers, right? But so often our patients who are weak from a neuromuscular perspective often have facial and other bulbar weakness and can't make a seal on the device that is used to check these numbers. And they can sort of look very concerning when the patient may not or can be a little bit difficult to interpret. So I appreciate you giving us sort of the protocol and then the pearls of the caveats of how to interpret them and going sort of back to basics. So just looking at the patient at the bedside and how hard they are working to breathe or how difficult it is for them to clear their secretions from bulbar weakness. Moving on to another topic, you have a really wonderful section in your article on detecting clinical deterioration in patients in the neuro ICU. So many patients in the neuro ICU, for example, due to head trauma or large ischemic stroke or intracerebral hemorrhage, subarachnoid hemorrhage or status epilepticus, they can't communicate with us to tell us something is getting worse. And they can't, in many cases, participate in the examination. They may be intubated, as you said, sedated, or maybe even not sedated. And there's not necessarily much to follow on the exam to begin with if the GCS is very low. So I'd love to hear your thoughts and your pearls as someone who rounds in the neuro ICU almost every day. What are you looking for at the bedside to try to detect sort of covert deterioration, if you will, in patients who already have major neurologic deficits, major neurologic injury or disease that we're aware of, and trying to see if there is some type of difference at the bedside that would lead you to be concerned for some underlying change and go back to the scanner or repeat EEG, LP, etc.?
Yeah, I think that's an excellent question because that's a lot of what we do in the neuro ICU, right? And, when you read your plans, your residents say like, Q&R neuro checks, right? We often do that in many patients. But I think in the right patient, it can really be life or death a matter. And that it is the exam that really then drives a whole cascade of changes in management and, detects the need for life-saving procedure. I would say it depends very much on the process and what you anticipate, right? If you have, for example, someone with a large ischemic stroke, large MCA stroke, especially, right? Then, there's sometimes conversations about doing surgical procedure before they herniate. But let's say you kind of watch them and are worried that they will. You do worry about uncal herniation and you pay attention to the pupil because often if the inferior division is infarcted, you can see that kind of temporal lobe tickling the uncus already. And so I think those are patients that I torture with those NPI checks and checking the pupil very vigilantly. I would say if it's a cerebellar stroke, for example, right, then you think about, hydrocephalus. And often patients with cerebellar stroke, the beauty of it is that if you detect it early, those patients can do so well, but they can die and will die if they develop hydrocephalus, start swelling. But I think often something I always like to teach trainees is looking at the eye movements in up gaze and down gaze, because often as the aqueduct in the third ventricle gets compressed and there's pressure in the colliculi, you kind of see vertical gaze get worse. But I would say I think it's always good to kind of know what the process is and then what deterioration would look like. For example, in subarachnoid hemorrhage, where you talk about vasospasm, it's funny, I think a really good experienced nurse is actually a best tool in this. But they will sometimes come to you and say, I see this flavor, and it's actually constellation of symptoms. Especially in the anterior ACA ACOM aneurysms, you sometimes see patients suddenly making funky jokes or saying really weird things. And then you see that in combination with sometimes a sodium drop, a little bit of subfebrile temperature, blood pressures shoot up sometimes, and that is a way the brain is sometimes regulating. But it's often a constellation of things. And I think it depends a little on the process that you're worried about.
Yeah, that's very helpful. You just gave us some pearls for detecting deterioration related to vasospasm in subarachnoid hemorrhage, some pearls for detecting malignant edema in an MCA stroke or fourth ventricular compression in a large cerebellar stroke. Patients I find often very challenging to get a sense of what's going on and often get scanned over and over and back on EEG, not necessarily find something. Patients with large intracerebral hemorrhage, particularly in my experience if the thalamus is involved, just can fluctuate a lot. And it's not clear to me actually what the fluctuation is, but you're looking for whether they're developing hydrocephalus from third ventricular compression with a thalamic hemorrhage. Probably shouldn't be seizing from the thalamus, but if it's a large hemorrhage and cortical networks are disrupted and it's beyond sort of the subcortical gray matter, or has the hemorrhage expanded or ruptured into the ventricular system, and yet you scan these patients over and over sometimes and just see it's the same thalamic hemorrhage, and there's some probably just fluctuation in level of arousal from a thalamic lesion. But how do you, as someone who sees a lot of these patients, decide which patients with intracerebral hemorrhage, what are you looking for as far as deterioration? How do you decide who to keep scanning when keep seeing the same fluctuations on EEG? I find it so challenging. I'm curious to hear your perspective.
Yeah, no, that is a very tricky one. And I mean, unfortunately, in patients with deeper hemorrhages or deeper lesions, thalamic or then affecting brainstem, I think those are the ones that ultimately don't have good, consistent airway protection and do end up needing a trach just because there's so much fluctuation. But I agree, it's so tricky. And I don't think I can give a perfect answer. I would say a little bit I lean on the imaging. And for example, let's say there's a thalamic hemorrhage. We recently actually had a patient, I was on service last week, that had a thalamic hemorrhage with a fair amount of edema on it that was also kind of pressing on the aqueduct and didn't have a lot of IVH, right? But it was from the outside pushing on it, and where we ended up getting more scans. And I have to say that patient actually just did fine and actually got the drain out and didn't need a shunt or anything, and actually never drained. We put an EVD and actually drained very little. So I think we're still bad at gauging those. But I think in general, my index of suspicion or threshold to scan would be lower if there was something a lot of IVH associated, if, this kind of push on the aqueduct. It's very hard to say, I think. I mean, sometimes as you get to know your patients, you get a little bit of a flavor of what is within normal fluctuation. I think it's probably true for every patient, right? That there's always some fluctuation within the realm of that's what he does. And then there's something more profound. Yeah, sorry, I wish I could give a better answer, but I would say it's very tricky and requires experience. And ideally, you're really taking the time to examine the patient yourself, ideally several times. And, sometimes we see the patient and we get really worried, or the typical thing we see in the ICU is that the neurosurgeons walk around at 5 a.m. and say she's altered, she's different, she's changed. And then the nurse will tell you at 8 a.m. No, they woke up and they ate their breakfast. And so I think really working with your nurse and examining the patient yourself and just getting a flavor for what the realm of fluctuation is.
Yeah, that's helpful to hear how challenging it is even for a neurocritical care expert. I'm often taking care of these patients when they come out of the ICU, and I'm thinking, am I scanning these patients too much because I just don't sort of see the initial stage? And then, you realize if I'm concerned and this is not fitting, then I should get a CT scan. And sometimes you can't sort it out at the bedside. So far from apologizing for your answer, it's reassuring, right? That sometimes you really can't tell at the bedside as much as we value our exam, and the stakes are quite high if this patient has developed intraventricular hemorrhage or hydrocephalus, and these would change the management. And sometimes, as you said, these patients, the first few days in the ICU, or for us when they come out of the ICU, are getting scanned more often than you would like to, but then you get a sense of, oh yeah, these times of day, they're hard to arouse, or they're hard to arouse, but they are arousable in this way. And then when they are aroused, this is what they can do. And that's kind of what we saw yesterday. And yet, as you said, if anyone on the team, the resident, the nurse, the student, our neurosurgery colleague says, I don't think this is how they were yesterday, then very low threshold to just go back and get a CT and make sure we're not missing something.
Exactly. Yeah, I would say the other thing is also certain time intervals, right? If I'm seeing a patient that maybe in vasospasm kind of around the day 7 to 10, in the first 14 day, I would be a little bit more nervous. Or with swelling, acute ischemic stroke, there's like a peak swelling window in which I would just be more anxious or have a lower threshold to scan. Yeah.
Yeah, very helpful. Well, thank you so much for joining me today on Continuum Audio.
Thank you very much, Aaron.
Again, today we've been interviewing Dr. Sarah Wahlster, whose article, Examination and Workup of the Neurocritical Care Patient, appears in the most recent issue of Continuum on Neurocritical Care. Be sure to check out Continuum Audio episodes from this and other issues, and thank you so much to our listeners for joining us today.
This is Dr. Tisha Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practice. And right now, during our spring special, all subscriptions are 15% off. Go to continuumpub.com/spring2024 or use the link in the episode notes to learn more and take advantage of this great discount. This offer ends June 30th, 2024. AAN members, go to the link in the episode notes and complete the evaluation to get CME. Thank you for listening to Continuum Audio.